Good morning, good afternoon, good evening, clinical problem solvers. It's Tuesday. It's Neurology Morning Report. And it's nice to see everyone this morning. And you know the routine. We need a volunteer to present a case and 2 volunteers to discuss that case. Ideally, one identifying as a woman and one identifying as a man. And I have to go to a work meeting at 10 a.m. Pacific time in 57 minutes. So please volunteer soon so we can start on time, so we can end on time. Let's see if that will compel anyone to volunteer a little more quickly today so I don't get in trouble with my boss at work. What do you think? Silence. This was an ineffective strategy. It's true. I'm not making it up. Who would like to volunteer this morning? We really need you to volunteer. People want me to get in trouble. Yeah, we want you to get fired from your job so you can be a full-time clinical problem solver. I would love that. Unfortunately, not sure that will pay the bills for now. Anyone like to discuss this morning? You might be thinking it's neurology. I don't know. It'll be fun. I promise. You've seen it a few times now, probably. You might be thinking English isn't my first language, so I'm not sure. Well, we have speakers of so many languages here: Spanish, Portuguese, Hindi, probably other languages as well. French. None of these are working this morning, please. All right, I will reveal that we have a case as a backup just in case. Now, can we please have 2 volunteers? Nilayan, fantastic, a frequent flyer, great. And we'd like someone to join the line. We have 2 out of 3 now. There's ideally someone identifying as a woman to join Nilayan and Maria. Anyone? All right, Maria and Nilayan, why don't you start introducing yourselves? And I'm sure someone will be inspired by your wonderful introductions to join you.
Oh, am I audible?
We can hear you, Nilayan. Yeah.
Oh, hello everyone. My name is Nilayan. I'm a final year student from New Delhi, India, and been a frequent flyer here. As Aaron mentioned, I'm really glad to discuss. I hope this gives me all the confidence so that I can carry it to the wards. Our medical college is opening really soon.
Great, wonderful. Thank you for volunteering. And Maria, I think everyone knows you. You posted a famous video on Twitter about clinical problem solvers in Espanol, which was amazing to see. But just introduce yourself just in case.
Yeah, I had totally forgot about that. My name is Maria. I'm from Guatemala, and I have a case. It's all by memory because I was a very messy student, so I have nothing from when I was in med school. And yeah, if you speak Spanish or want to learn Spanish, we have a new site for you in the CP Solvers main website.
Which is amazing. All the schemas in Spanish. There are Spanish voiceovers of the schema videos. Okay, Valeria, also a frequent flyer, has volunteered. Anyone else? Not that we wouldn't be happy to have you, Valeria, but anyone who was waiting until this last moment and thought if no one else does, anyone like to join? Maybe next week, you're thinking, maybe next week. Okay, I'm seeing those thoughts, maybe next week, and I want you to volunteer next week. Great, Valeria, do you want to quickly introduce yourself and then we'll go ahead and get started?
Yes, hello everyone, I'm Valeria, I'm from Lima, Peru. And yeah, we're super excited to discuss today. I was doing teaching points actually, but just to save Aaron's job, I'm volunteering. Super excited.
That is very nice of you. I appreciate it. And when it comes time for teaching points, if we're near the end, I may have to disappear, but I will leave you in the good hands of the teaching points teachers. Okay, with that, let's go ahead and get started. I think Kirtan will be scribing, which is awesome. And so Maria, do you want to give us just the chief concern, chief complaint to get started?
Yes, I can't wait because it's visual hallucinations.
Wow, visual hallucinations. Valeria, what are you thinking?
Okay, so I'm thinking if it's something on the optic kind of track, think starting in the eye, something affecting the eye and the retina, if it's unilateral or bilateral, if it's a hallucination in all the like I don't know, I just lost the word, but if it's
Visual
in all the
field?
space,
Yeah.
yeah, sorry, in all the visual field, or it's only one part. Visual hallucinations also makes me think of seizures, of the possibility of an occipital seizure, just because I think I have seen a case before. And so, yeah, something going on in the retina, going backwards. I think visual hallucinations are things that I wouldn't necessarily think of, maybe like usually preceding a seizure or a headache, maybe something more organic, thinking about something more localizing in the brain itself. Just kind of thinking of other possibilities like psychiatric or something like that, that would be less likely just because of visual hallucinations. I think another type of hallucinations may be more correlated to that. So yeah, that's kind of what I'm thinking.
Yeah, fantastic thoughts, Valeria. So yeah, when we first hear hallucinations, right, as you said, if this wasn't neurology morning report, we might be thinking of a psychiatric etiology, but you're right, auditory hallucinations for whatever reason are more common in disorders characterized by psychosis. So you're right that visual hallucinations can localize anywhere along the pathway. We think of the brain, right, as sort of the place that has vision, and so it would be the place where you would invent vision if that's what's happening in hallucinations. But you're right that problems in the eye itself can cause hallucinations. Did you have something particularly in mind there, Valeria? Because there is a phenomenon worth mentioning. I'm wondering if you were thinking that, or I can add as well.
No, not really. I would love to learn it from you.
Yeah. So patients with visual loss of any etiology can have what are called release hallucinations, where they start to see things in either the blind or nearly blind visual field, or this is very common in older patients who develop macular degeneration or just age-related visual loss, that they have what are called release hallucinations. This is called the Charles Bonnet. Oh, good for you. Someone just threw it in the chat, Charles Bonnet syndrome. So you can actually get hallucinations from the eye. We wouldn't think of, again, if Maria is just being particularly broad to make our discussion broad, if this were floaters or not well-formed hallucinations or sparkling lights, right, those could all be retinal phenomena. But just the phenomenon of visual loss, the Charles Bonnet syndrome, can cause auditory visual hallucinations. And you can get a similar phenomenon in the ear with age-related hearing loss. I had a patient that kept hearing music and was thinking it was the neighbors and all of this stuff, and it was age-related hearing loss, and she had sort of a release hallucination, auditory hallucination. But then most of the things we think about are in the brain, as you said, and we would think of some type of cognitive disorder related to the visual pathways, right? That is somehow malfunctioning and causing the patient to see things that aren't there. But you brought up a rare but interesting point that there are occipital seizures. And so we know when a part of the brain seizes, it causes whatever function there, right, to occur. Those cells are firing and they have a normal role. And when they fire abnormally, that role they perform ends up getting performed involuntarily. So the obvious example, right, is tonic-clonic movements, right, when you have seizure activity in the motor cortex. But we know about the deja vu type of aura. That is probably seizure activity, or that is seizure activity spreading to the medial temporal lobes where we recognize memories, right? And if you have seizure activity there, you have a feeling of, oh, I recognize that. The rising autonomic sensation probably near the insula where a lot of autonomic sensation comes. And so if you keep following that logic back to the occipital lobe, right, if you have firing of occipital neurons due to epileptic activity, you can have visual hallucinations as part of the seizure. Usually these are well-formed shapes and figures. So things like a bright square or a particular colored square. One of my colleagues shows a video of the rainbow spinning wheel when your computer crashes, that rainbow that the patient was describing, that they kept seeing that spinning wheel in their, whatever it was, left visual field, and had a focus of occipital seizures. And we talked once in this morning report about a patient I had who had a small occipital stroke and presented with secondary migraine, presented with a visual aura that sounded like migraine, sparkling lights going across the visual field. And that was a secondary migraine due to stroke. And we actually discovered the patient was seizing from that stroke as well. So it was secondary migrainous phenomenon from probably stroke and seizure in the occipital lobe. So uncommon, but worth knowing about. It would be pretty atypical to see a fully well-formed hallucination like a person or that sort of thing from an occipital seizure. Usually it's earlier visual processing regions, the ones that are telling us that something is bright or a square or tilted or dark or whatever, and those are the ones then cause shapes of that nature in an occipital seizure. Good, and then well, let Nalayan chime in. Other ways you can think of visual hallucinations arising here. We talked about psychiatric conditions. We talked about Charles Bonnet phenomenon, the release hallucinations from visual loss, which can be from the eye, but could be anywhere you can get visual loss, which can occur all along the visual pathway. And we talked about occipital seizures. Any other things on your mind related to visual hallucinations, Nalayan?
Yeah, I think you also mentioned migraine, which was, I was thinking about that. And I think you even mentioned diffuse Lewy body disease, which is also a good differential. And regarding that psychiatric and psychotic point, I wanted to elaborate on that. That visual hallucinations can be divided into formed or unformed. Formed would be, as you said, elaborate hallucinations that would be involving complex imageries. And that is usually a sign of psychiatric illness. And it's important to note that the patient has insight or not, whether the patient is aware that the patient is hallucinating or not, because a lack of insight almost always indicates a psychiatric or a psychotic episode. So something like schizophrenia should be in the loop. And that's all. I think you and Valeria covered all the points.
Yeah, great point. Yeah, I wanted to make sure we got neurodegenerative disease with Lewy body dementia on the table as well, right? So how do you get visual hallucinations from Lewy body dementia? It's not entirely clear, but some things that I've read are pretty interesting. So we've talked many times, so we won't spend the time this morning about how visual information gets from the eyes back to the brain. Optic nerve, optic chiasm, optic tract, lateral geniculate nucleus, radiations, occipital lobes, all that good stuff, right? If we were talking about visual fields. But once we get to the occipital lobe, we have this interesting thing called the binding problem. If you've heard philosophers talk about this, you have cells in the occipital cortex that respond to the particular orientation of a line, right? Hubel and Wiesel won the Nobel Prize for this, probably in the, I don't know, 50s, 60s, someone can look it up. And there's videos of them doing these experiments in anesthetized cats where they were recording from the occipital cortex and they would show them a line, and certain cells fire when the line's at 0 degrees, other ones fire when the line is at 10 degrees, 20 degrees, etc. Do I have time? I can't resist. It's such an interesting story of serendipity in science that they didn't really know what they were looking for. They were putting these slides on a slide projector and trying to see what would make the neurons fire. This is one of the early electrophysiology experiments, and nothing was working. They couldn't get the cells to fire. And then they went to take the slide out of the slide projector. And you know, these experiments, they have the electrodes hooked up to an amplifier to hear the sound of electrical firing. And as they're pulling the slide out, they hear the cells start firing. They think, what is going on? It's happening when the slide is pulled out. And they realize when the slide is pulled out, if you've seen these old slide projectors, right, that it creates a straight line across the visual field. And all these things they were trying to show them, color shapes, were too complicated. And once it was just that line, and that was the serendipity by which they realized what cells in the occipital cortex do and began the study of neural coding and won the Nobel Prize. So the first early cells are just saying like, it's a line in this direction. And the next one says, it's a line in my direction. The next one says, and so the whole visual world we see is broken down into lines and curves and colors and shapes, and then proceeds anteriorly along the visual pathways to reconstruct the environment. So this is called the binding problem. How do you like take your house, like pull it into a million pieces and throw it on all over the place and then put it back together? The brain is doing that everything we see, which is totally extraordinary, right? Okay, I couldn't resist that. Hubel and Wiesel story I think is so interesting. And you can find a YouTube video, because I've shown this to medical students in classes, of them talking about the experiments as black and white videos of doing the experiments, you know, as long as you don't mind seeing an anesthetized cat with electrodes in its brain, which is not the usual cat thing you see on YouTube these days. Okay, so back to Lewy body dementia, right? Maria's laughing, thinking there's no way he's going to make it to his 10 o'clock meeting. And I'm okay with that. So you get to the primary visual cortex where everything's broken back down. And then how do you build it back up? There are two pathways. There's a dorsal stream called the where pathway that goes to the parietal lobe, and a ventral stream called the what pathway that goes into the temporal lobe. So the parietal lobe sort of telling us where things are in space, where we are in relation to things. That's why parietal lesions on the right anyway can cause neglect, right? This problem with spatial attention. And the what pathway, that's involved in recognition memory, right? How do we know what something is? Because we've seen it before, or we've smelled it before, or we've tasted it before. And that pattern matching of something in the environment and some stored percept is how we know what something is, called recognition memory. So I'm almost back to Lewy body dementia. The idea is that, so we know in Alzheimer's disease, right, there's degeneration of the medial, temporal, and parietal lobes in particular. And in Lewy body dementia, interestingly, little known fact, or at least was little known to me until I started reading about this, is there is occipital degeneration in that condition. Not usually so much that you can see on a scan, but on nuclear imaging studies or SPECT, one of the regions of early involvement in the cortex in Lewy body dementia is the occipital region. So these patients can have visuospatial dysfunction at onset. I had a patient, or I didn't know the patient, I studied the patient on my neuropathology rotation, the patient's autopsy, who had Lewy body dementia. And he had all these problems with his eyes. He kept, when his cat was on the couch, we have a lot of cats this morning, he kept sitting on his cat because he couldn't detect the cat from the background of the couch. And he kept missing things when he went to pick them up. And this was simultanagnosia and other higher order visual problems. He went to an eye doctor, he had cataracts, they took him out, he didn't get better. Finally, he saw a neurologist who said, you have visuospatial dysfunction. And that was from occipital involvement from early Lewy body dementia. And so the hallucinations are thought that maybe when you knock out these problems of the occipital lobes, that then you're somehow disinhibiting parts of the what pathway that have all these things in them, and they start sort of bubbling up to consciousness involuntarily. And that maybe that's part of the etiology of hallucinations. Usually in Lewy body dementia, as Nalayan astutely said, the patient is aware they're not real, and they're usually very characteristically little people and little animals, where a patient will say, I looked out the window, I thought there was a parade of children, and then I looked and they weren't really there. So they're not threatening like in schizophrenia. They're sort of kind of benign. I saw a bunch of little animals outside, and then I realized that they were hallucinations. Okay, so as a starting point, we're wondering, could this patient have visual loss causing release hallucinations? If this patient has intermittent sort of primary shapes, is this occipital seizures? Or does this patient have neurodegenerative disorder like Lewy body dementia? Other conditions there you could see hallucinations. Well, anything probably that could cause psychosis more broadly. So things like limbic encephalitis. So what causes a limbic encephalitis? Herpes encephalitis can do that. Have I seen it present with hallucinations? No, but could do. And then limbic encephalitis, such as an autoimmune encephalitis. Things like NMDA encephalitis. Do they usually present with hallucinations? No, usually sort of amnesia changes and neuropsychiatric changes. But I think you probably could get hallucinations, but not 100% sure. Okay, that was fun, Maria. Thank you. Can you tell us about, do we have any time left to talk about the case? A little bit of time, great. Please, someone find that Hubel and Wiesel YouTube video and put it in the chat. It is so amazing to see these guys talking about this big accident that led to neural coding and the Nobel Prize with these slides being taken out of the projector. Okay, tell us the HPI, Maria.
Yes,
Please.
I love the discussion, especially because, serendipity is like my favorite word, especially because it's so scientific, but yeah. So let's see, the patient came in with, the patient was like 60-year-old man, came in with his daughter and his wife. They did most of the talking due to language barriers. This is not from Guate, this is from Spain, and the man spoke Catalan and just a little bit of Spanish. So the daughter was very concerned because she says the father had been acting strange for the past 2 to 3 years. He was constantly getting lost in his neighborhood, despite having lived there his entire life, and had started talking with his brother, who passed away passed away over 20 years ago. He often comments that on like little animals, saying things like, "Oh, what a pretty dog," when there's no one around. His wife is also concerned. She says that he has good and bad days. He sometimes stares blankly, and she doesn't feel comfortable with him driving anymore because he seems to get lost all the time and stares blankly at space. He has had urinary incontinence for the past 6 months. And when asked if the father has any concerns, he says that sometimes his wife tells her, he tells his wife that he sees things that aren't there. And that's the second aliquot. I think I can give like the past medical history, not really that significant. So he has hypertension and diabetes, adequate medications, no idea which were they. He used to work as a salesman, but has been retired for the past 5 years. And yeah, he spoke Catalan.
And you might have mentioned this, Maria, but the time course overall, was this for months, for years, for weeks?
For the past 2 to 3 years, and they've noticed it.
Okay, great. Nalayan, you're up first this time.
Yeah, sure. So a few points popped up when I was hearing to Maria. First thing is, the man is 60 years old. So that predisposes him to etiologies like degeneration. I would like to prioritize degeneration over other etiologies. Plus, the man patient has a chronic course of disease. So that alone puts something like infection or an aneurysm or a vascular cause much behind something like degeneration. Okay, and apart from that, getting lost in the neighborhood and blank stare sounds to me something like related to memory loss could be. So a brief, I thought the patient might be dementia, might have dementia, dementic. So dementia plus urinary incontinence, I'm not sure how to tie them up, but I was saying something like normal pressure hydrocephalus, that could have urinary incontinence, and wet, wacky, wobbly is how I remember it. So we do have wet and wacky. Maybe we can get wobbly. And apart from that, I cannot think of any specific neurodegenerative disorders. I have not read enough. But yeah, that's all I was thinking.
Yeah, great points. 60 is not that old. I find myself as I get older. I remember one of our first of my mentors, who some of you have seen do these online case discussions, Marty Samuels, when we would say an elderly man presented, and we would say he was 70, he would say, now that I'm 70, I don't consider that elderly, and we didn't see him as elderly. So I'm not that close to 60, but just joking around aside, would still be a little bit young for a neurodegenerative disease, just to throw that out there. Although frontotemporal dementia, which this does not sound like, tends to present, can present a little younger than Alzheimer's and Lewy body dementia. Those, but that's just the averages, and patients can present relatively young. So that aside, I agree with you. This has been going on for years. So infectious, inflammatory, vascular, most of those things are sort of off the table here. And a degenerative process seems likely, though there are other things that can fool you. A very slow growing meningioma in the right place, benign tumor that grows very slowly. I've seen patients present for what looks like depression, and they have just a large frontal meningioma that's been there for years, just getting bigger. A chronic subdural hematoma at years would probably be a little long for that, but I saw one patient who I really thought had Alzheimer's disease, and we got a scan and it almost looked like more subdural hematoma than brain. The subdural was so big, and had been probably not years, but certainly months. And you're right, the other features here are all cognitive. You said, how can we link the urinary incontinence? One way to connect those dots, as you said, would be normal pressure hydrocephalus, which has the triad of walking difficulty, urinary incontinence, and cognitive dysfunction. The walking dysfunction in NPH is almost always the first aspect, almost always the first symptom sign. And the urinary aspects and the cognitive aspects almost always emerge later. So question often comes up in practice, right? A patient has cognitive changes and gets a scan and their ventricles look big, and everyone wonders, is it NPH, normal pressure hydrocephalus? And usually the answer is no, actually. As patients get older, all of us, our brains get smaller. and there's something called hydrocephalus ex vacuo, meaning that the ventricles just kind of expand to fill that space to maintain equilibrium, because there's atrophy. And there are ways, if NPH becomes more relevant when we hear about this patient's gait later, we can talk about how you would distinguish ex vacuo hydrocephalus from hydrocephalus, because the ventricles are actually getting bigger. But without walking difficulty, it would be pretty hard to invoke that, and we didn't hear about walking difficulty here. So those are some great thoughts, I think, putting us in the degenerative space, making us wonder about NPH, although without the gait, probably less likely, and there may be other ways to connect the dots of urinary incontinence and some of these other symptoms. Valeria, any thoughts, additional thoughts you had on differential diagnosis or other things that jumped out in the history to you at this stage?
Yes, I was thinking also about something like a dementia syndrome. And so considering things like Alzheimer's, but we don't really know if the patient has had some problem with his memory. But also I think the fact that visual hallucinations and the fluctuating status, and also that urinary incontinence, that I think is part of neurological sensitivity. I'm not sure, but I think it's part of Lewy body dementia that we were just talking about. And so I was thinking about that because frontotemporal lobe dementia, I would expect something more like maybe changes in behavior, something not quite like mild as this, but something more like, I don't know, unusual behavior, something inappropriate maybe, not so much about getting lost. I know that Lewy body dementia also has Parkinsonism, and so we don't have that here, but maybe it's an early stage. I don't know exactly how is the time course of that dementia. But yeah, I was thinking about the possibility, and well, Alzheimer's disease maybe, but just the fact that I didn't know exactly if urinary incontinence was part of like the early stages, just because the patient didn't refer any major changes in memory or in daily activity. So I would expect that to come before. So yeah, that's what I was thinking.
Yeah, fantastic thoughts, Valeria. So when we think about dementia, that's sort of a syndrome, not a disease, right? So this is a progressive cognitive or neuropsychiatric changes to the point that the patient can no longer do their activities of daily living. So when we think about dementia, we often think about the degenerative etiologies, Alzheimer's, frontotemporal dementia, and Lewy body dementia, but there's a broad differential diagnosis for dementia itself, right? And we always want to make sure we're not missing any reversible causes of dementia. So we mentioned some of those: tumors, subdural hematomas, large list of toxic metabolic, right? Thyroid dysfunction, liver dysfunction, renal dysfunction, syphilis causing neurosyphilis, HIV causing HIV-associated neurocognitive disorder, kirtan, but B12 deficiency, yes, you beat me to that. B12 deficiency, vitamin deficiencies, Wernicke's encephalopathy, usually acute, right, from thiamine deficiency, autoimmune conditions, some of the autoimmune encephalitides, antibody-mediated syndromes, neuropsychiatric lupus. So huge, long list, right, of reversible causes of dementia that we always want to exclude with imaging and some relatively extensive lab workup before telling a patient we think they have a degenerative etiology, because as we know to this stage, none of those are treatable. There is some symptom management, and as you know, if you've been watching the news, a lot of debate around the FDA's approval of aducanumab, but I'm going to still say, even with that, there is no treatment for these degenerative diseases that's effective as far as we know. So if we're down the path of thinking about a degenerative cause of dementia, right? So not a tumor, not a subdural hematoma, not a lab abnormality, not a CSF abnormality, although there are CSF abnormalities in neurodegenerative diseases. That's another story we might talk about. Then we're really thinking about the ones that Valeria and Nalayan have mentioned, Alzheimer's disease being the most common, Lewy body dementia being the second most common, and frontotemporal dementia being the third most common. Vascular dementia is also worth mentioning. The patient has hypertension and diabetes. On the STEP exams, right, the USMLE, it's always stepwise. Patient has a stroke, they get a little confused, has another stroke, get a little. In real life, that's actually very rarely the case, almost all of you have seen scans where the radiologists write periventricular white matter changes consistent with chronic microvascular disease, right? This is subclinical strokes or subclinical vascular changes that over time cause disruption of neural circuitry and cause a dementia. And that's vascular dementia. That's probably, I don't know if it's second most common after Alzheimer's or where it stacks up. I think that's the case. And in reality, we'll talk about how to distinguish some of these clinically, which Valeria began talking about. Studies have shown that we're not that great while the patient is alive predicting what pathology they're going to have. And some of that reflects the challenges of clinical diagnosis, and some of that reflects how we don't really understand these diseases very well, and part of why people are debating this aducanumab and whether the amyloid hypothesis that the buildup of amyloid in the brain is even the cause of Alzheimer's, or it's just some byproduct that removing it doesn't seem to have a great effect. So classically, as Valeria mentioned, in Alzheimer's, the predominant deficit is in memory. There's medial temporal lobe degeneration, and memory is the predominant problem. This getting lost could be a general sort of inattention, executive dysfunction that can be a little bit non-specific, but if it's truly the patient is doing pretty well otherwise, but gets lost in the grocery store, gets lost driving, that's more of a parietal, again, where pathway sort of thing. And that's pretty common in Alzheimer's disease as well. Again, we always think about temporal lobe, but there is parietal atrophy early on as well. That's the classic presentation, but there are other presentations of Alzheimer's disease, particularly younger onset Alzheimer's disease can present atypically. And there's something called the visual variant of Alzheimer's or posterior cortical atrophy. There's predominant occipital degeneration, and patients can present with balance syndrome, which is simultanagnosia, optic ataxia, and ocular ataxia and optic apraxia, or optic and ocular may have confused. They're confusing terms. We could explain them later if they become relevant on the exam. So that's a variant. The primary progressive aphasias, the logopenic variant, has Alzheimer's pathology. Obviously, this patient's not talking about problems with speech, but you can get speech problems throughout any of these dementias. But if speech is the predominant problem, it's called a primary progressive aphasia, which there are 3 variants, 2 of which are frontotemporal pathology, which is confusing, and one of them is Alzheimer's pathology. So not all Alzheimer's is memory loss. Okay, and so frontotemporal dementia, as Valeria said, is more neuropsychiatric dysfunction, behavioral changes, and these patients often first go to psychiatrists, right? They have changes in their mood, they have changes in their personality, they have changes in their eating habits. And if you, when they make it to a neurologist, the syndrome is recognized, but the presentation looks like a psychiatric presentation with behavioral changes, although to my knowledge, not much in terms of hallucinations. And then Lewy body dementia, which as Valeria says, has a triad of hallucinations, fluctuations in the level of consciousness, and Parkinsonism. We haven't heard about Parkinsonism in the history here, but sometimes the Parkinsonism is subtle and you just pick up on exam some rigidity or a gait dysfunction that this patient is not that old, but an older patient people had sort of put aside, where the Parkinsonism is not the major feature for the patient or for the clinician, it's more the cognitive aspects. When I was a medical student trying to memorize this, you all know I don't love mnemonics, but this one, when I had Lewy body, I remembered hallucinations and fluctuations, and then the Parkinson's has Lewy bodies in the pathology as well, so that helped me remember that. The fluctuations are actually interesting. I, like all of you, memorized that as a medical student and didn't really know what to expect. But these can be very dramatic. This patient is staring off or a little confused and then comes back to normal. We would wonder about seizures also. I saw a patient transferred to our hospital once in Boston who looked comatose and was comatose, although was breathing and CT scans were normal, and had a history of Lewy body dementia, and the next morning just kind of woke up and was back to baseline. And the family said, yeah, she does this. And I was asked one of our cognitive behavioral specialists, like, is this like a Lewy body fluctuation? This is really, she said, yeah, it can be, very extreme, not always that extreme, but that is there. What about the urinary incontinence? This patient is not old enough that we could just say, well, they're old and that happens, right? We talked about NPH. Valeria, you mentioned that this could fit with Lewy body dementia. Do you know how? I'm not looking for the detailed mechanism, but how it sort of fits in a general way.
I am not sure, but I mean, I knew that it was autonomic insufficiency that could be part of neuroleptic sensitivity, such as also patients having, for example, syncope, or to like transient loss of consciousness and stuff like that. So I thought maybe that could fit in that symptom. Yeah,
you got it. So synuclein pathology. So we talk about all these diseases with their names, but what's very confusing is that pathologists use the same term. So there's frontotemporal dementia is a syndrome. Frontotemporal lobar dementia is a pathological pattern that can be seen in frontotemporal dementia, but also in other diseases. And what's even more confusing, to my point before, is on autopsy, a lot of patients have some Alzheimer's pathology and some Lewy bodies in there, or they have some tau pathology. And so it gets, we don't know. We don't know what's going on with these diseases, but lots of people are trying to figure it out. So that's right. Any synuclein related disease, so Parkinson's disease, the pathology has synuclein buildup, Lewy body dementia, and then multiple system atrophy, less common degenerative disease. And you can have MSA-P, which is MSA with Parkinsonism, or MSA-C, which is MSA with cerebellar dysfunction. And they have very prominent autonomic dysfunction. But any synucleinopathy, so Parkinson's disease as well as Lewy body dementia, those patients can have autonomic dysfunction as well. Orthostatic hypotension, as Valeria said, is very common. Urinary difficulties, constipation is very common in Parkinson's disease. And actually, I think in the latest criteria for Lewy body, one of the ancillary tests you can use to diagnosis is myocardial scintigraphy, and there's some evidence of cardiac deafferentation or something like this, or deferentation. So yes, we have a lot of arrows here pointing towards Lewy body dementia, given the time course moving us toward degenerative, unless Maria has some surprises for us in the labs that this patient has syphilis or something like this causing a degenerative syndrome. But this cluster of symptoms is really so specific, right, for Lewy body, that's hard to imagine a secondary etiology, but hard to imagine doesn't mean not the answer. So on the exam here, we'd definitely be interested in the patient's mental status, right? And then we'd be interested to look for signs of Parkinsonism, which could include rigidity. I mentioned gait. Nalayan, Valeria, what other signs of Parkinsonism might we look for here on the exam?
Tremor. Okay.
Tremor, yeah. So in idiopathic Parkinson's disease, which this patient doesn't have so even more confusing, there's Lewy body dementia, and then there's Parkinson's disease dementia, where patients with Parkinson's can get demented over time. People used to use this 1 year or 5 year rule that they keep changing, that if you have the rigidity and the tremor and the other features of Parkinson's, years before the dementia, you have Parkinson's disease. And if you have the dementia together with it, or first, you have Lewy body dementia. But again, these boundaries keep getting blurred as the molecular markers get better. So yes, we would look for tremor. And in idiopathic Parkinson's disease, the tremor almost always begins unilaterally and stays asymmetrically. Whereas in Lewy body dementia, often the tremor is bilateral at the onset. I'm not sure if that's in the literature, but that's my experience. And it's not always a resting pill rolling tremor. You can kind of see anything. Good. So tremor, rigidity, what else might we look for?
I think we can look for bradykinesia. And if the patient has a complaint of falling, then it points towards atypical Parkinsonism. So balance disturbance. So that would maybe not points towards typical Parkinson's. And
yeah, so bradykinesia, right? The slowing of movement. So we ask patients to finger tap big and fast, right? And they'll be a little less good at it in their non-dominant hand. You can see I'm right-handed because my left hand is a little slower and clumsier. But bradykinesia will be slow and it will get small. It's both of those things, slow and it gets small. You can say screw in a light bulb really fast. And again, it's not sort of clumsy, but it's slow and kind of small, stamp their feet. And you don't want to have them do it together because in idiopathic Parkinson's disease, there's asymmetry and the patient can kind of entrain to the better hand. So if they do this, that's sort of cheating. You really have to look at the hands together. Yes, Maria's checking and looks like she has no bradykinesia today. Very good. Fantastic. Good. And then we would be looking at the gait as well, as Nalayan said. Very good. And you mentioned this term atypical Parkinsonism. So there's Parkinson's disease, idiopathic Parkinson's disease. And then there's what's called Parkinson's plus or atypical Parkinson's. Those are conditions that have Parkinsonism, that have bradykinesia, rigidity, and tremor, but are not Parkinson's disease, but are still degenerative, which are all under the umbrella of primary Parkinsonism, not on the other side of secondary Parkinsonism from medications or otherwise. So the atypical Parkinson's conditions, well, we've mentioned some of them, Lewy body dementia, we mentioned MSA, and anyone know the other two? There's two more that are very rare that are in this atypical Parkinson's category.
Yes, Ethan mentioned corticobasal degeneration, and then we had progressive supranuclear.
Good for you. Yeah. So one of them is called corticobasal syndrome, to distinguish from corticobasal degeneration, which is the pathology that can be seen in that condition, but not always. You can get Alzheimer's pathology causing corticobasal. So this is where all these things get super confusing. Corticobasal syndrome is another very asymmetric syndrome with Parkinsonism. They often have myoclonus or other movement disorders or cortical sensory deficits on the abnormal side. You can have something called the alien hand syndrome, which when you read about it, sounds like the hand is doing all sorts of very elaborate things. In my experience, it's a little more subtle than that, the hand is just sort of doing what looks like semi-voluntary things that the patient is not asking it to do, but it's not like the hand is like writing a check and mailing it or something like that, as elaborate. And then progressive supranuclear palsy, there's very early falls. You can fall from Parkinson's disease, but usually it's not an early finding. And there's a vertical gaze problem. Up gaze, actually, deficits in up gaze are actually pretty common as people get older. That can be normal or sort of non-specific, but deficits in down gaze are not normal. And that's more specific for progressive supranuclear palsy. And then they all have Parkinsonism. So again, this doesn't sound like MSA, this doesn't sound like PSP, this doesn't sound like CBS, but just to round out our Parkinson's plus, where you'll see also in the literature, atypical Parkinson's, Lewy body dementia, MSA, PSP, and CBS/CBD. Okay, Maria, what did you and your colleagues find on this patient's physical exam?
Okay, that was really fun. So I'm gonna just do everything so that you have time to run. So basically the patient, when we got back, we had to like leave for like a second. We got back, he was really sleepy. The wife said he's sleepy all the time. She says he's sleepy because he doesn't sleep well at night. They've been sleeping in separate beds for the past 10 years because he used to like shout and like move his legs and arms all the time. So she decided to move to another bedroom. We did like mini mental test, and it was being really messy here. So he was oriented to person and place, not really time. Then we did like the mental status, the mini mental test, and it was really difficult because of the language barrier, but he did speak some Spanish. So it was 20 out of 30. Notably, I remember that, registration and recall was normal. I don't remember how you say that, but when you have to like spell the words backwards, he couldn't do that. And then the subtraction was also abnormal. And then the copying of the pentagons was really abnormal. He had really difficult time doing them. If you've ever seen them, they're supposed to be like overlapping, but he did them like really separate and not at all like the image. We also asked him to draw a clock, and he drew mostly like an oval, and most of the numbers were outside of the clock or like on the border of the circle, like not really how a clock looks like. And then those things that like tell the time were really big for the clock. I remember them. The rest of the exam, he had a resting tremor, which was symmetrical in both hands. No rigidity, and he had a normal gait. So we did all the tests.
Hold on one second. I know you're trying to save me for my meeting, but there's just so many goodies there that are more important than this meeting. Hopefully they can't hear me. So thoughts on that sleep thing, Valeria or Nelayan? Does that mean anything to you? Yeah.
I'm not sure, but I think if he's asleep he wakes up with shouting and terrors in the night. I just thinking about maybe he's having some well, a longer onset of disease, and maybe he's having hallucinations or some sort of night terrors that could be part of the delirium that we are kind of making a syndrome of. So I don't know if that confirms as our delirium syndrome here.
Yeah, one possibility, patients with poor sleep. This is also in the differential for reversible causes of dementia, sleep apnea. If you know from medical training, right, how it feels to stay up all night or be woken up a million times in the night, your mental status is not so great the next day, is it? And so if patients are doing that every night, sometimes CPAP can be the cure for their dementia. I think this is something a little more specific. Nalayan, do you recognize this? This is part of a syndrome here. I think you might have been getting at Valeria, but just to take it over the finish line.
Oh, well, I was right there with Valeria, and I thought this is something like REM sleep disturbance. So I equated this with sleep terrors, as Valeria said. And I remember something like sleepwalking and sleep talking is REM and non-REM 3 and 4 stages feature, and sleep terror is typically a REM feature, but I'm not very sure. And so I thought this is this could be sleep terror, as a patient might be experiencing REM sleep disturbance, and then consequently the patient feels tired during the day and wants to sleep. So that is somewhat typical.
Yeah, sleep is one of my weak areas. I don't know too much about it, but this is one condition I know something about because of its relevance to other neurologic diseases. And so I think sleep terror is a more specific thing in kids, but I could be wrong about that, and don't quote me on it. But what this sounds very much like is REM sleep behavior disorder. And what this is that during REM sleep, you should be atonic. You don't move. You might move a lot in your dream, but you're not moving in real life. And for some reason, REM sleep disorder, the patient does move. And very classically in this disorder, patients have dreams of being chased, of being fought with, very violent dreams. And you can YouTube some very striking sleep study videos where these patients are punching and kicking and throwing themselves out of the bed. They're not sleepwalking, they're not sleep talking, but they are acting out their dreams with their limbs. And the bed partners get punched and kicked and all kinds of things like that. And it's been discovered that this is part of the prodrome for synuclein-related disease. And again, if you have bad dreams once in a while, this is not the same. Whenever we teach this, people say, oh, I have bad dreams. But this REM sleep disorder, I forget the latest data, but something like within 20 years, 70% of patients will have a Parkinson's-related disorder, synuclein disorder. And within 40 years, if the patients still have like something like 90%. Don't quote me. There's a recent Lancet review on REM sleep disorder. But it can be in isolation and have nothing to do with anything, but very high predictive value that loss of smell are sort of parts of the prodrome. And there's a theory that the synuclein is sort of almost like a prion-like protein that's starting in some of these areas and then spreading throughout the brain to cause the rest of the syndrome. So that is another sort of clue for us that we are in the camp of a synuclein related disorder. So that's REM sleep disorder. All right. Other aspects of the resting tremor we have to talk about, right? That I think is a gimme. We'll just say that it's symmetric, right? Which would be atypical for typical Parkinson's disease and more typical for atypical Parkinson's disease. But what about the mini mental as far as what the deficits were? Does that help us here at all? So the clock drawing, the pentagons.
So I believe the abnormal clock touch is for a non-dominant parietal lobe. That's how I remember it from MCA stroke. The MCA stroke in the non-dominant parietal lobe typically causes this abnormal clock touch. If I'm not wrong, I think I'm equating this with neglect syndrome. Are these two the same?
Yeah, those are different. Yeah, good question. So the non-dominant parietal lobe causing neglect, they might draw half of the clock or put all the numbers on the right side and nothing on the left. Here, there's sort of more constructional aspects, I would say, in terms of drawing the clock, drawing the pentagon. So I wouldn't necessarily put that in parietal. Any other thoughts, Valeria or Nalayan? Where would you localize the clock drawing problem and the let's put calculation aside, because I think that was more the attentional clock drawing and the pentagon drawing.
I have no idea, honestly.
Yeah, so these are visual. and probably, the parieto-occipital, so the sort of where pathway, that junction of where visual information starts becoming more complicated, presuming, of course, the patient has motor skills and coordination and can draw on all of these things. So we see here deficits in executive dysfunction, attention, so the counting backwards and the days of the week backwards, and visuospatial. And again, those are the two most common cognitive domains in Lewy body. We think of, right, hallucinations and fluctuations and Parkinsonism, but visuospatial dysfunction and executive dysfunction are the sort of cognitive hallmarks. And those are borne out in some of the studies Maria's team may or may not have been able to do. So if you might be pretty sure at this point, this is Lewy body dementia, and this is probably enough to say so. Are there any tests that could prove this, do you know, or prove it as best we can with the patient still alive? Valeria and Nalayan?
You mentioned something like SPECT, so is that an acceptable answer here?
Any answer is an acceptable answer. So right, so often these patients on structural imaging, MRI or CAT scan, there won't be too much that's obvious, not like the medial temporal lobe or the frontotemporal degeneration in Alzheimer's and FTD respectively, just sort of maybe some generalized atrophy, nothing specific. But if you use nuclear imaging like SPECT or PET, there are particular patterns of hypometabolism or decreased uptake for the neurodegenerative diseases. Alzheimer's, again, temporal, parietal, frontotemporal, frontal, temporal, and Lewy body, interestingly, occipital. There's some temporal, some parietal, but occipital is sort of the main distinguishing feature. So again, this is a test that can be expensive to get. And if you're pretty sure clinically and you've excluded other things, do you really need it? Probably not, but in a research setting, or if there's some ambiguity, or for a more specific diagnosis, you can get PET or SPECT and look for patterns of hypometabolism or decreased uptake, and you'd be looking for occipital out of proportion to others. So what happened next, Maria? I'm seeing if I'm getting the timing just right, unless you say. Then we did a lumbar puncture and his AFP was positive.
No. Well, we did like the test, like just to confirm that there's nothing extra. So CBC, BMP, thyroid, vitamin B12, syphilis. I don't remember which other, like any others, but everything came back normal. Yeah, everything normal. CT scan showed like cerebral atrophy, slight, like nothing abnormal, like nothing really abnormal. And so final diagnosis was, as you've all been mentioning for the past 55 minutes, Lewy body dementia. So yeah, that was the case I had for today.
Great case, Maria. Thank you for bringing us this case, and it allows us to talk about lots of interesting things. And Valeria and Nalayan, brilliant discussion here, getting to Lewy body from just the chief complaint and then finding things that landed in that column and some that maybe pulled us away, but we always found our way home to that diagnosis. I am going to make someone else the host for the teaching points, which look extensive and wonderful. Thank you, Maria and Kirtan, and I'm going to make it on time to my meeting as if nothing has happened. And I will, on my way out, put in the chat the case I mentioned of the patient who was sitting on his cat and got his cataracts, who I met on my neuropathology rotation through his autopsy. He wanted people to learn from his condition. And so donated his brain for study in the neurodegenerative pathology group where I used to work. And that case was presented at our neuropathology conference. We wrote a clinical reasoning case in which I was where I learned and ended up reviewing all of this sort of anatomy and physiology behind the visuospatial aspects, behind the hallucinations, and even so that acetylcholinesterase inhibitors used in Alzheimer's, rivastigmine and donepezil and all those, again, they do not have a major effect, but have some benefit, also have some small benefit in Lewy bodies. And there's some evidence for how the cholinergic pathways sort of project to these areas that can be causing hallucinations. So some of that is in there as well. I'll throw that in the chat if anyone's interested in congratulating us for finishing Neuro VMR before 10 a.m. Yeah, it's the first time I've had a record in this direction. Usually each week we're sending it in the opposite direction. Anyway, wonderful case, Maria, brilliant discussion, Valeria, Nalayan. Thank you, Maria and Kirtan. I will throw this in the chat and see myself out at 9:59. Thank you, everyone. Have a wonderful day, night, and week, and I'll see you next week.
Let's see if this doesn't end, but just to recap all of the teaching points that Vale and Nilayan and Aaron shared, this was a very interesting case. I saw it in my rotation when I was a 5th-year medical student, and it was a long time ago, and it was close to Christmas, and I was not wanting to be a neurologist, so didn't really pay a lot of attention to it, but I'm really thankful for it a couple of months, years later. So we started with visual hallucinations that can mean a lot of things, and so it can very interestingly can be caused by normally we think about psychiatric, and as Valim mentioned, those are mostly auditory, and people usually don't have good insight, and they're usually associated with a lot of other psychiatric characteristics. When they're neurological, people usually have good insight, and then they're visual, and they can be things from very simple geometrical figures to, I had a patient who had temporal seizure abnormalities who hallucinated superheroes, and she was treated for schizophrenia for many, many years until she got the right diagnosis. We then saw more aspects of the case, which led us to think about dementia. And dementia, is like an umbrella for a lot of other specific disorders. So you have to be, as you did here, think about what is the prominent features and the other special features to really nail the diagnosis. So the usual triad for MPH, for example, is dementia, urinary incontinence, and gait abnormality. If we have young patients, we tend to think of other causes like frontotemporal dementia, Lewy body dementia, Huntington if they're really young. If the memory abnormalities is the predominant feature, we tend to think about Alzheimer. If it has a stepwise deterioration, we tend to think about vascular dementia. And then, you always want to rule out reversible causes. Even we don't usually do the test that we do for the dementia workup to confirm or deny the diagnosis. It's just because it's a degenerative disease, you really want to make sure that you have the diagnosis correctly and you're not missing out on reversible causes that can possibly bring that person to his normal state. So think about tumors, subdural hematomas, toxic and metabolic causes, infections, nutritional causes, autoimmune encephalitis, and even sleep apnea. So there's an extensive workup before diagnosing a degenerative untreatable dementia, and always think about it. And then during the physical exam, the Mini-Mental test and the clock test analysis is really special because, first of all, they're really hard to do. They take a lot of time. So, cognitive neurology is, I think it's very special because it's very detailed, and you have to have a very good rapport with the patients and everything. And in this case, you can tend to prioritize which points is the patient missing, and not only see the Mini-Mental test as a score, but really what are the functions that are being affected. So for example, if they draw half a clock, you might think about neglect syndromes. If in this case, the pentagon and the clock drawing is very abnormal, think about visuospatial dysfunction. If it's arithmetics and spelling, think about executive function. And if they tend to miss out on the points for registration and recall, it's mostly a memory dysfunction. And then we have a lot of different names and syndromes overlapping Parkinson and Parkinson plus syndromes. So first of all, what is Parkinson's symptoms? They tend to be tremor, bradykinesia, rigidity, and have gait abnormalities. And so idiopathic Parkinson is what we know as Parkinson's disease. And they tend to have a predominance of motor symptoms as opposed to frontotemporal dementia, which has a predominance of neuropsychiatric symptoms, or Lewy body dementia, which has a predominance of hallucinations and fluctuations and visuospatial abnormalities. So these are all synucleinopathies, and then we don't really know much. We do know a lot about the disease, but we're still learning about them. So a lot of people think that it's basically a part of the spectrum, and then as more markers arise, we might see there might be the same disease at different time points, or they might be completely different. Only time will tell. So the true takeaway point from this is about Lewy body dementia. So always think about it, if the patient has some sort of cognitive abnormality, particularly if it's visuospatial abnormalities and it's a fluctuating cognitive disorder. It's not progressive or it's not constant, but the fluctuations tend to be really the key point. And then they do have visuospatial abnormalities. And as Vale pointed out, also they have autonomic instabilities. And as Aaron told us, these disorders are basically diagnosed in biopsies when the patient dies. But then if you really take a look at the most predominant features and the criteria, then you can do a diagnosis like we did in this case for Lewy body dementia. So I hope you guys liked it. Hope to see you again next week. And yeah, enjoy your week, everybody.